Bismillah ar-Rahman ar-Rahim. First of all, I'm very glad to attend and participate in the Egyptian EDDW 18th. First of all, I want to thank my dear professor and mentor, Professor Dr. Serag Zakaria, for this opportunity, and Professor Dr. Mohamed Ramadan Baddar, my godfather, for this opportunity to participate in Egyptian EDDW 18th. We will talk today about gastroesophageal reflux disease. The Montreal definition for GERD is a condition developed when reflux of stomach content into the esophagus, causing troublesome symptoms plus or minus complication. 10 to 20% of the population are affected by GERD, caused by imbalance between normal defensive mechanism of the esophagus and offensive factors such as acid and other digestive juices and enzymes in the stomach. Epidemiology of GERD in Western population, GERD affect 10 to 20% of population, 0.4 newly developed cases. In Canada, 3 to 6 million Canadians are suffering GERD. Developed nations tightly linked to age, about 60 to 70 years of age, affected, and pregnant females. 20% of the people have symptoms per week, and 7% experience symptoms every day. No data supporting sex predisposition in GERD. The symptoms of GERD range from acidic taste in the mouth, regurgitation, heartburn, pain during swallowing, sore throat, increased salivation, non-water breath, nausea, chest pain, coughing. In children, can also experience GERD in the form of repeated vomiting, effortless spitting, coughing, respiratory problems as wheezes, crying, refusal of feeding, leading to failure to gain weight, adequate gait weight, bad breath. Children have more than one symptom, and usually they respond within and recover within 1 year of age. The complication of GERD range from reflux esophagitis, causing inflammation of the esophageal epithelium, causing ulceration near the junction between the stomach and esophagus, esophageal stricture, persistent narrowing of the esophagus caused by reflux-induced inflammation, Barrett's esophagus, which is intestinal metaplasia, change in the epithelium from squamous to intestinal columnar epithelium of the distal esophagus, which is a precursor condition for esophageal cancer, often cause esophageal carcinoma. GERD also has extraesophageal symptoms like recurrent ear infection, otitis media, idiopathic pulmonary fibrosis, chronic sinusitis, asthma, linked to laryngopharyngeal reflux, and reflux dental erosions also seen. The pathophysiology of GERD range from multifactorial, lower esophageal sphincter dysfunction, defective esophageal clearance, hiatus hernia presence, delayed gastric emptying, and any cause causing increased intra-abdominal pressure. The transit relaxation of the lower esophageal sphincter has a major role. 75% of the episodes of GERD, symptomatic GERD, happens, and with delayed gastric emptying, it's a cofactor in 20% of GERD cases. What increases the transit lower esophageal sphincter is obesity, pregnancy, smoking, hiatus hernia. Many medications can cause increase in the transit lower esophageal sphincter, like antihistaminics, calcium channel blocker, antidepressant, non-steroidals, and steroids. Zollinger-Ellison syndrome, hypergastrenemia, leading to increased gastric acid secretion and due to gastrin production. High blood calcium level, increased gastrin production, leading to increased acidity. Systemic disease like scleroderma and systemic sclerosis, causing defective esophageal motility and causing esophageal dysmotility. There is association between GERD and other diseases as like obstructive sleep apnea. Gallstones impede the flow of bile in the duodenum, which can ability to neutralize the gastric acidity. H. pylori infection is just an association, not a causal factor. Diagnosis of GERD by history, mainly by history. No other investigation are needed. Typical symptoms are present. Once practiced diagnosis of GERD, short-term treatment with the BBI is very efficient. Improvement of symptoms suggesting positive diagnosis. Differential diagnosis of GERD is chest pain, ranging from non-serious to serious life-threatening condition. We must exclude cardiac patients, especially in male above 40 years. Cardiovascular events like acute coronary syndrome, angina, myocardial infarction, pulmonary embolism, respiratory conditions like pleurisy, pneumonia. This is very important. Chest wall myositis or psychogenic causes must be excluded before diagnosis of GERD. Investigation for GERD patient only for patients who do not improve on medical treatment. What we'll do, upper GI endoscopy is the first line of investigation for the patient. Ambulatory pH monitoring can be used for patients who do not improve after BBI. Esophageal manometry prior to surgery is needed, very important to do before surgery. Investigation of H. pylori and barium are not needed and not helpful in the diagnosis of GERD anymore. Endoscopy allows direct visualization of the esophagus, stomach, and the duodenum, not routinely needed if the case is typical and responding to treatment. Some physicians advocate that we can do upper endoscopy once in life or 5 to 10 years yearly endoscopy for long-standing GERD for evaluation of presence of dysplasia or occurrence of Barrett's esophagus. When we must do endoscopy, if there is alarming symptoms or red flags in the GIT. What are the red flags in the GIT? Bleeding, overt bleeding like hematemesis, melena, bleeding per rectum, or visualization of blood in the stool may be chemically lab, not overt by the patient. Dysphagia, it's important condition to do upper GI, wheezes or voice changes, loss of weight, iron deficiency anemia, long-standing symptoms, no response to PPI after 4 to 6 weeks. These are the alarming symptoms, red flags, urgently do endoscopy. What we will see in the endoscopy, we will see classification, Los Angeles classification for esophagitis in GERD grade A, one or more mucosal breaks, not longer than 5 millimeter, does not extend between top of 2 mucosal folds. LA classification grade B, one or more mucosal breaks more than 5 millimeters long, does not extend between the top of 2 mucosal folds. LA classification grade C, one or more mucosal breaks that continues between the tops of the 2 mucosal folds but do not involve more than 75% of the circumference of the esophagus. We can see esophagitis leading to peptic stricture in the esophagus due to near the junction of the stomach. This is complication for GERD causing dysphagia or difficult swallowing. Do we need endoscopic biopsy in GERD? Usually it is not routinely needed to do during the gastroscopy because it will see edema, basal hyplasia, lymphocytic infiltration, non-specific inflammatory changes. There is term of esophageal eosinophilic esophagitis, intraepithelial eosinophils, more than 15 eosinophils per high power field in the distal esophagus to diagnose eosinophilic esophagitis. Barrett's esophagus, we will see in the pathology goblet cell intestinal metaplasia, dysplasia or carcinoma. Usually reflux changes not obvious, not elusive, so the term is NERD. Severity of GERD scoring system, Johnson Demister scoring system, 0, none, 1, minimal occasional episodes, 2, moderate medical therapy visits, regular visits to the patient to the hospital. 3, severity that interfere with daily activity, absence from his job and daily activity disrupt his quality of life. NERD, this is more than 60% of GERD patients who do upper GI with no finding. NERD overlaps with patients with functional dyspepsia and IPS. Quality of life decreased as the symptoms increase in patients with GERD. Esophageal pH monitoring, most objective test to diagnose reflux disease. Monitor GERD in the response to medical treatment or surgical treatment before any surgical or endoscopic intervention to be considered. This confirm the acid reflux in patients with persistent symptoms without mucosal damage with trial of acid suppression if failed. It's done using 24-hour transnasal pH or pH impedance or Bravo wireless capsule for 48 hours. Manometry, placement of fine flexible tube through the nose into the esophagus. It measures the contractile pressure of the esophagus and the esophageal musculature and the lower esophageal sphincter, measure the contraction, test the coordination and the force and the coordination of the esophageal muscles. It very helpful in diagnosis of this diffuse esophageal spasm. They are multiple, forceful, poorly coordinated muscle contraction of the esophagus. Achalasia, lower esophageal sphincter does not relax properly, so leading to severe dysphagia, and also the manometry help in diagnosis of scleroderma. Treatment of GERD, lifestyle modification. Lifestyle changes is the mainstay in the treatment. Most important line of treatment is lifestyle modification with medication and surgery reserved only to patients who do not improve in the first two line measures. Lifestyle modification include do not lie down for 3 hours after eating, raise the head of the bed, losing weight, avoid food which result in symptom, and avoid smoking. The medication could be used as proton pump inhibitor, H2 receptor blockers, and antacids. Prokinetics only used if there is additional association with functional dyspepsia or IBS. We insist the patient to avoid coffee, citrus drinks, tomato-based products, carbonated beverages, chocolate, peppermint, fatty or spicy food. Avoid eating within 3 hours of bedtime. Avoid smoking as much as you can. Avoid alcohol as much as you can. Avoid excess weight gain, and losing weight is very beneficial. The goals for treatment of GERD: to eliminate symptoms, to heal esophagitis, to manage and prevent complications, and maintain the patient in remission. Regardless any endoscopic findings, erosive or non-erosive, most patients with typical symptoms treated with BBI and give good response on BBI. So uncomplicated GERD, initial therapy of empirical treatment with BBI is appropriate. The medication used, proton pump inhibitor, most effective once daily. If there is partial response to treatment, can be given twice per day. And we rely upon this very much and stress upon this very much. The patient should take the PPI pill 1.5 hours or 1 hour or half an hour before the meal. No significant difference between PPIs, different PPIs. The lowest effective dose should be taken. We should take on-demand therapy if the patient improved. Once symptoms occur with frequent problems, we take on-demand therapy. H2 blockers give response in 40% only. Antacids 10% if combined with alginic acid improve symptoms to 60%. Prokinetics not used alone and not used especially except if there is associated functional dyspepsia or IBS added. There is claim for adverse events for effects for BBI, so we stress upon not continuing using it for chronic duration, for long-standing duration. We prefer on-demand therapy if the patient symptoms are controlled. There is published papers about its relation with chronic kidney disease, dementia, bone fractures, Campylobacter or Salmonella infection, spontaneous bacterial peritonitis in patients with cirrhosis or ascites, Clostridium difficile infection, micronutrients. All these are observations, not yet resulting in clinical evidence or warning symptoms, but recorded cases. There is no association between BBI long-term use with and myocardial infarction, bacterial overgrowth or pneumonia, or gastrointestinal malignancy. Thanks God. Sucralfate, effective as H2 receptor blocker, need multiple doses, this limiting its use. Baclofen is a GABA agonist, effective, also need frequent use for and greater adverse events. Immediate release omeprazole, long-acting dexlansoprazole, potassium competitive blocker, PCABs, a gamma receptor agonist, baclofen, decrease transient lower esophageal pressure. Maintenance therapy, recurrent symptoms after cessation of BBI, Barrett's esophagus, especially in elderly patients, LA grade C, extraesophageal manifestation of GERD. All these categories and kind of patients can and must have maintenance therapy for BBI for GERD. For initial patient with esophagitis, we start with PPI till the symptoms are controlled. We subsequently try to step down the intensity of therapy, 40 milligrams and 20 milligrams day after day, or maintenance treatment down to the lowest dose that controls the symptoms without requiring to repeat the endoscopy for the patient. We can take on-demand therapy or weekend dosing to minimize the side effects for long-term use of PPI. 50% of patients with heartburn do not have esophagitis, need acid inhibitory treatment with antacid to maintain the quality of life. On-demand therapy, low-dose PPI, effective strategy in these patients. We must tailor the acid inhibition to decrease the severity of GERD, and acid-related disorder is an attractive approach. Refractory GERD is 40% of patients with GERD fail to have responded symptomatically, partially or complete to the standard dose of PPI for 12 weeks. The refractory GERD can present as incomplete or lack of response to PPI therapy. The causes may be non-reflux related due to severe dysmotility of the esophagus, achalasia, which was not diagnosed properly, scleroderma, esophageal esophagitis, pill esophagitis, or infectious esophagitis. Reflux related, persistent acid reflux due to PPI related, large hiatus hernia present, patient have Zolliger-Ellison syndrome, nocturnal breakthrough for the patient. Duodenal reflux of bile, impairment of esophageal integrity, esophageal hypersensitivity, and psychological comorbidities for the patient is an important cause for non-response of the patient to standard treatment. The factors related to PPI delayed action, inadequate dosing or proper timing, not fasting and not taking within meals, or rapid metabolism. Next step to be done, we can increase the dose of the PPI, we can add H2 receptor blocker, we can shift to another PPI and add on H2 receptor blocker, do upper GI endoscopy to visualization for proper visualization of the esophagus, stomach, and the duodenum, or do pH metry. Eosinophilic esophagitis is chronic inflammatory disease of the esophagus characterized by dense tissue eosinophilia refractory to standard PPI therapy, affect all groups of age groups, mostly between 20 to 50 years of age. Topical steroids are effective. 15-day course of treatment with budesonide, well tolerated and highly effective, inducing histologic and clinical remission in the adolescents and adult patients with active eosinophilic esophagitis. Surgery is nasal fundoplication, the upper part of the esophagus wrapped along the lower esophageal sphincter to strengthen the sphincter and prevent acid reflux and to repair the hiatus hernia. Strata procedure using electrode to apply radiofrequency energy to lower esophageal sphincter found can 2012 systematic review found can improve GERD symptoms, while in 2015 meta-analysis showed that did not support the claim that strata can be effective management or treatment of GERD patients. Add on to its high expense. Link system endoscopically can wrap the lower esophageal sphincter or transoral incisionless fundoplication. This applicator will introduced with the endoscopy and position at the junction between the stomach and the esophagus. Then device will peel and fasten the tissue fold. Then it will be repeated multiple steps to ensure the gastroesophageal valve prevent the reflux of stomach fluid content into the esophagus again. Thank you very much. I would like to thank
would you lead us?
Professor, sorry for this internet connection error. Thank you, Professor Osama. I have one question just for 1 minute. Can I? Do you hear me, sir? Okay. Professor Osama?
دكتور اشرف look at the camera.
سامعني حضرتك كده؟
ايوه خليك كاميرا، هات كمان كده شويه الشمال كده يمين
كده كاميرا كده فل. تمام. بروفيسور اسامه. Yes, non-acid reflux, alkaline reflux, and so. What about the management?
ايوه يا فندم.
احنا اتكلمنا عن الاسيد ريفلكس. اوكي. انا بسأل على النون اسيد ريفلكس.
النون اسيد ريفلكس ايوه.
الالكلاين بيبقى فيه الكلاين ريفلكس، مش يعني من البي اتش مونيتورنج احنا بنعملها علشان برضه نبقى عارفين ان ده اسيد ريفلكس، مش كده؟ انا بسأل على النون اسيد ريفلكس مانجمنت.
ايوه يا فندم.
جيرد برضه جاستروسوفيجيال ريفلكس ديزيز من ضمنها النون اسيد. يعني هل ما بيبقاش اكيد يعني عايز بس
مش عارف اسمع كويس
كلمه صغيره. نعم.
طبعا هو كان
الصوت
مش عارف الصوت تاني، في حد مشغل صوت تاني داخل.
وكان معانا كل فتره يعني
حد مشغل حاجه تانيه؟
طبعا يعني انا عاوز اشكر كل واحد.
بروفيسور سراج سامعنا؟
انا مش عارف اسمع كويس يا دكتور اشرف.
ولا انا برضو يا دكتور اسامه. ايوه، طب تسمعني كده؟
Osama, you are in a busy place. We cannot continue this, okay? So معلش دكتور أشرف, would you ask your question and we discuss it together?
كده مش أيوه.
Osama in the university, they're busy with I know what.
Yes, okay.
So what's your question?
My question, non-acid reflux diseases. احنا قلنا جرد، يعني المحاضرة كانت جرد.
Like bile for example. After cholecystectomy.
ايوه.
Biliary reflux.
بنعمل فيها ايه يا
دكتور؟ Very serious and yes. What's the question?
بنعمل فيها ايه؟ انا مش عارف انا سامع ولا مش سامع.
In these cases we add mucosal protection and we add orthodoxycholic acid, alkylating agents, and with PPI acid reduction as well.
تمام.
This is terrible, very terrible. What's your opinion, Ahmed? احمد فؤاد ازيك؟
انا شايف ان لازم حتى لو نون اسيد برضه لازم
English Ahmed please.
I think that even in non-acid we even need to put PPIs because there may be hypersensitivity even to low dose of acids. So we need to put PPI and we use prokinetics.
So the PPI in acid and non-acid reflux.
Okay.
And non-acid, yes.
Do you think, my colleague, that combination of PPI with prokinetic would help in GERD or insignificant?
I think using prokinetics is essential in GERD.
Yes.
Because patient will not improve only on PPIs. He needs prokinetic also. Even from the start.
So you recommend the combination therapy? Okay.
Dr. Ahmed recommend.
According to the latest guidelines, the use of prokinetics is reserved for patients with proved delayed gastric emptying. Otherwise, the addition of prokinetic does not add too much to the relief of the symptoms of GERD. Only in patients with proved delayed gastric emptying.
The dilemma, you are right, and gastric emptying and also some prokinetics work down. I mean, the lower part is the colon.
Functional.
Help in evacuation of the colon, and this help also more regulation of the motility of the GIT from esophagus to the rectum. I think we move to our next speaker. Please introduce him.
Our next speaker, Professor Dr. Mohamed Salah Abdelbari. Dr. Mohamed, Management of Upper GI Non-Variceal Bleeding. Welcome, Dr. Mohamed.
Hello, hi, Dr. Serag. Hi, my dearest professors. First, I would like to thank my dearest professor and mentor, Professor Dr. Serag, for his kind invitation for this conference. We will discuss today management of non-variceal upper GI bleeding. Okay. Slideshow. Management of endoscopic management of non-variceal gastrointestinal hemorrhage. Can you listen to me, Professor Dr. Serag?
Yes,
I hear you.
Okay. Okay. The instance of cases, it's about 1 per 1,000 of general population per year. In the most cases, the bleeding stops spontaneously. Only minor cases present with significant hematemesis or melena and account for most of the morbidity. If we try to define the causes of upper GI from a management point of view, we have variceal bleeding, which constitute 2/3 of the cases, non-variceal bleeding, in which more than 50% are caused by peptic ulcers. The other common causes include erosive gastroduodenitis, esophagitis, malarivice, angiodysplasia, de la Foy, and neoplasia. And we have obscure upper GI bleeding. Prior to endoscopy, the European Society of Gastrointestinal Endoscopy does not recommend nasogastric or orogastric lavage. It recommends only IV erythromycin single dose, 250 milligram, given 30 minutes to 2 hours prior to endoscopy, and this will ensure proper visualization during endoscopy. It enhances gastric emitting. Timing, the European Society recommends early endoscopy within 24 hours, but the very early endoscopy recommended when there is hemodynamic instability that persists despite volume resuscitation, or there is a contraindication to the interruption of anticoagulation. This will bring us to anticoagulation. We have patients with antiplatelets presenting as taking antiplatelets for primary prophylaxis. Just we withhold low dose aspirin and re-evaluate the risk and benefits of ongoing low dose aspirin, and we can resume the low dose aspirin after ulcer healing. If the patient taking antiplatelets for as a secondary prophylaxis, either we have a massive bleeding and we on low dose aspirin alone, so we will stop low dose aspirin and we can resume it after 3 days following endoscopy. Or he may have a dual antiplatelet aspirin and Plavix, so we continue on low dose aspirin without interruption, and we do early cardiological consultation for recommendation on continuation of the second antiplatelet. If this minor bleeding and we are taking anti-platelet as a secondary prophylaxis, if on low dose aspirin alone, and continue. If on dual, and continue also. Patients taking vitamin K antagonist, Marivan, with massive bleeding, and stop Marivan and give vitamin K 5 to 10 milligram IV infusion over 30 minutes, and prothrombin complex concentrate 25 to 50 international urine per kilogram according to baseline INR, when recheck INR every 30 minutes after prothrombin concentrate infusion. If INR less than 1.5, we will do urgent endoscopy. In patients with minor bleeding with INR less than 5 and omit 1 dose of vitamin K antagonist and close monitoring, between 5 and 9 and stop vitamin K antagonist with oral vitamin K, more than 9 and stop vitamin K antagonist and give IV vitamin K, and consider endoscopy for evaluation. For patients taking direct oral anticoagulants and with massive bleeding, we do fluid replacement and consider gastric lavage if those within less than 3 hours, and consider hemodialysis, and we may consider prothrombin complex concentrate. If minor bleeding, can delay or discontinue next dose. Peptic ulcer, the European Society recommends the Forest classification to be used in all patients with peptic ulcer hemorrhage in order to differentiate low and high risk endoscopic stigmata. According to Forest classification, Forest 1A arterial spurting, 1B oozing, 2A just a visible vessel, and 2B adherent clot, 2C flat pigmented spots, and Forest 3 clean base ulcer. Risk stratification by combining clinical and endoscopic criteria. We used Rockwell score, which combines 5 domains: age, comorbidity, hemodynamic stability, bleeding source, Forest classification to predict rebleeding and mortality. This is rebleeding risk according to Forest grading, and risk of rebleeding, we notice that it's high along categories 1A and 1B, and it became lower after. Peptic ulcer bleeding, F1A and F1B and F2A should receive endoscopic hemostasis. High risk for persistent bleeding or rebleeding. فهن use contact thermal, mechanical therapy, or injection of a sclerosant agent as a monotherapy, or combining these techniques with epinephrine injection, which should not be used as a monotherapy. F2B endoscopic clot removal, then endoscopic hemostasis. This is a peptic ulcer bleeding, F1A, F2A, combined diluted epinephrine injection and direct thermal. Here we are injecting diluted epinephrine في البريفري of the bleeding spot. Now we notice in the still vessel with active bleeding, we will do ABC argon plasma coagulation for the vessel. Press hard on the vessel, and this is the result. Okay. This is a peptic ulcer bleeding, F2B, clot removal, and ABC and mechanical. This is a large blood clot. We will try to remove it with biopsy forceps. Now we will apply ABC, argon plasma coagulation. And we will use a clip for proper hemostasis. Okay. Peptic ulcer, if F forest 2C or F3 discharge home on standard BBI therapy. The European Society does not recommend the use of Doppler ultrasound or magnification in the endoscopy and assessment of peptic ulcer. If it's still bleeding uncontrolled, ESEHG recommends the use of hemostatic spray or Ovesco as salvage endoscopic therapy. Other causes of non-variceal upper GI hemorrhage, acid-related causes like erosive esophagitis, gastritis, or duodenitis. ESEHG recommends treatment with BBI. Maali device, if it's bleeding, we will do endoscopic hemostasis. If non-bleeding, just medical treatment. Cameron lesions, which are lesions, erosions or ulcers in the sac of a hernial hiatus hernia. Acute bleeding can be treated endoscopically with the standard hemostatic techniques. Surgery to repair the hiatus hernia can be considered in patient with recurrent bleeding despite of the above measures. Delafoy lesion, endoscopic hemostasis using thermal, mechanical as hemoclip or band ligation, or combination therapy, dilute epinephrine combined with thermal or mechanical. Here we will put a clip, hemoclip. Okay, successful. This is a band ligation of a Delafoy lesion. Other causes include gastric antral vascular ectasia, in which we can do endoscopic coagulation with ABC, or endoscopic band ligation, which has been proved successful, or portal decompression with TIPS angioectasia, endoscopic hemostasis therapy, and upper GI neoplasms endoscopic hemostatic therapy, including hemostatic nanopowder. This is a GAVE post ABC. Hemospray bleeding source treated include peptic ulcer versus tumor iatrogenic. Advantages are its ease of use, acting as an extinguisher even in difficult lesion, and its potential efficacy for different bleeding lesion. Disadvantage, inability to use another modality if the hemostasis should fail because the powder obscure the target site. L'Ovesco primarily developed for endoscopic closure of perforation of fistula, but it can be used for bleeding ulcers, arteries, chronic diverticuli, polyps, less than 1.5 centimeter in diameter, and mucosal or submucosal defects. Was success rate 90%. It's perfect. Post-interventional bleeding as post-ERCP bleeding, balloon sphincteroplasty, post-transplantation anastomotic stricture dilatation, intraductal biopsy and sphincterotomy. Placement of a fully covered metallic stent is indicated. Post-EMR or ESD bleeding and use of CAG forceps, coagulation forceps, where combined coagulation and clipping may add additional benefit. Post-endoscopic hemostasis rebleeding and repeat upper endoscopy with the hemostasis if indicated. The failure of second attempt and transcatheter angiographic embolization or surgery should be attempted. Medical therapy. Acid suppression can improve clot stability and platelet aggregation. IV omeprazole has been shown to reduce the risk of rebleeding with reductions in surgery and mortality. We use IV bolus 80 milligram to be followed by infusion 8 milligram per hour. Other options, IV infusion of somatostatins or other agents such as tranexamic acid or recombinant factor 7. Surgery between 5 to 10 patients will require surgery. Indication when continued or recurrent hemorrhage. Surgery should be considered early in patients at high risk of complications such as perforations, large deep anterior duodenal ulcer. This is algorithm showing all previously mentioned endoscopic managements. The obscure GI bleeding that constitute about 5% of all GI bleeding cases, and we do for it video capsule endoscopy, push enteroscopy, double balloon enteroscopy, single balloon enteroscopy, or intraoperative enteroscopy, imaging like barium, CT enterography, or CT angiography. Thank you.
Thank you, Professor Mohamed.
Thank you, sir.
Any question, Professor Serag?
Yes, Dr. Ashraf, you start the discussion.
Okay,
Dr. Hadi.
Dr. Mohamed, thank you very much. A lovely presentation and lovely videos.
Thank you, sir.
I wanted to ask you in cases of the Delafoy's lesions, because these are very, very tricky and you have to act quickly because very severe bleeding.
Yes.
Do you have any preference for the method? Because some people say you inject histoacryl, some people say you just put a clip, some people say you put a band, especially many people now are talking about the band. Do you have any preference for
yes, my preference is band ligation, and second preference is the clip. These are the reliable, most reliable methods I see. Injection of sclerosant material, question marks about it. I don't find it successful in most of the cases. I'm doing band ligation or clip, hemoclip.
Okay, and how about a special situation with the post sphincterotomy bleeding? I know you have extensive experience in ERCP and you face this a lot. It's a very
post sphincterotomy bleeding. I start injection. Spraying diluted adrenaline does not do any thing controlling bleeding, so it's not recommended at all. You may use to inject diluted adrenaline inside the sphincterotomy site. You may put do balloon sphincteroplasty. The balloon sphincteroplasty, we will inflate it at the sphincter, and we will use it as a tamponade for a few minutes. Or if it's still unsuccessful, I put 1 or 2 stents inside.
Yeah. Thank you very much, Mohamed.
Okay, thank you.
Mohamed, would you stress to us the importance of early admission to ICU in upper GI bleeding?
This is according.
Second question about intravenous versus oral PPI in upper GI bleeding, not very serious.
As regard we have a risk stratification for patient with upper GI bleeding. If I have a patient with compromised hemodynamics, which is not responding to volume resuscitation, with hemoglobin drop, with massive bleeding, these points all points to admission to ICU for proper observation and proper management of the patient. As regard the second question, we use IV infusion omeprazole with hemostatics, the drugs like diacinon, الكابرون, الكوناكيون في الفيرست لاين مانجمنت.
Okay. From
Thank you,
Mohamed,
very much.
Thank you, sir.
Yes, Dr. Asher.
To remove the blood clot or not to remove? This is
the recommendation is to remove.
Yes, to remove, but if you are, or if you have old procedures, right? Means
we supposed to have all the procedures. The recommendation is to remove, and we supposed to have the procedure so long. Yes, so long you enter into a hematemesis patient, you're supposed to have the
if
tools.
You don't remove and refer to another
center that it can manage. Yes,
because I saw a lot of problems due to removal of the clot without doing the maneuver.
The maneuver.
Agree?
Yes, of course, this is wrong.
Okay.
Okay.
Any other questions? Okay. No, I don't think there is other questions on the board. No. Okay. Thank you,
Okay.
Professor.
Thank
Dr.
you.
Mohamed.
Thank you.
Professor Dr. Serag.
And we thank Asino for the successful symposium, and we thank Dr. Osama Ashraf and Dr. Mohamed Salah for the two presentations, and see you in a coming event, inshallah. Now we move to Traveler Endoscopy Program, joint cooperation with European Society of Gastrointestinal Endoscopy and our society. Today we will have two communications with Professor Thomas Hackl and Professor Thomas Hackl from the Czech Republic and Stefan Herz from Hungary. And with us, Professor Ayman Yusri, Hani Shahab, Hisham Attan, Ahmed Hashim, Ali Farag, Khaled Serag. We have two communications, one about biliary stones management, the other about colorectal polyps management. We will start after 10 minutes. So Ahmed, we have some